Hi, I'm Dr. Phil Gauthier, Lead Senior Medical Director at Natera and a practicing transplant nephrologist. In this episode, we're going to hear from Dr. Sanjeev Akkina and Dr. Jessica Coleman. Dr. Akkina is the Medical Director of Transplant Nephrology at Loyola University, and Dr. Coleman is a nephrologist at the Nephrology and Hypertension Medical Associates of Georgia. Doctors Akkina and Coleman will discuss their kidney transplant surveillance strategies using donor-derived cell-free DNA. Highlights include Dr. Akkina's involvement in the proactive study and his protocol for his transplant recipients, Dr. Coleman's surveillance program, including a case study on how she advocated for her patient to the transplant center based on her suspicion of impending rejection. Spoiler alert, she was right. Their experiences on collaborative management and implementation strategies between referring transplant centers and general nephrologists to optimize care.
Well, thank you for having me do this presentation. Essentially, we're talking about the use of Prospera as a surveillance strategy for kidney transplant recipients. And with cell-free DNA and Prospera, it's just another tool to use in your patient toolkit, basically. Prospera has been shown to be very helpful in both clinical and subclinical acute rejections. For clinical acute rejections, you do see a sensitivity of about 86% in picking up acute rejections and a negative predictive value of 94%. Whereas with subclinical acute rejections, you can see a sensitivity of 92% and a negative predictive value of 98%. So using Prospera both for cause and for surveillance has been shown to be very effective in picking up acute rejections. What you'll get with a Prospera report is you'll see a longitudinal assessment of how your patient is doing with previous testing. So you'll see a percentage of the donor-derived cell-free DNA over time, and you'll see a cutoff at 1%. So it gives you an idea that if your patient has crossed over that 1% or still remains below 1%. It also below gives you a nice little table that shows you the actual count numbers or the copy numbers that you may see with these Prospera tests and the percentages. So you can kind of follow your patient over time to see if there are general trends. And we'll get to that. We'll see the importance of that in a few minutes. So with that background, we can now talk about the proactive study. So the proactive study is a prospective study looking at the use of cell-free DNA and monitoring for acute rejection in new kidney transplant recipients. The study includes over 4,500 patients in the test arm, with about 400 in the control arm. There's over 54 sites involved in the study, and this is to continue for a total of 3 years for all patients, and then the high-risk patients for rejection continue out for 5 years. The technology is, again, using donor-derived cell-free DNA, in this case Prospera, and the endpoints that are being assessed include, is there more effective use of biopsy in these patients? Also looking at the outcomes, including improved graft survival, and finally, the ability to identify subclinical and subclinical rejection compared to standard of care. So the interim data from the proactive study solidifies Prospera's use as a non-invasive surveillance tool. It's been found to predict antibody-mediated rejection up to 4 months and T-cell mediated rejection up to 2 months in advance of a biopsy-proven rejection. It's also shown that 9 out of 10 clinically stable patients had consistently low Prospera donor-derived cell-free DNA, less than 1%, so very low levels were a very good sign for the patient. And that elevations of cell-free DNA from baseline when using serial Prospera testing indicated an increased risk of rejection. So if you start to see those changes, they did see that there was an increased risk for rejection. So, I think there were some very important points, or so far some early results that have been very interesting from the study. To go back to the first point of rejection being picked up earlier with cell-free DNA, the proactive study looked at 1,631 kidney transplant recipients. 422 of these individuals met the inclusion criteria. These individuals had at least one biopsy and at least one Prospera test, and the test was drawn within 6 months of the biopsy. From this cohort, they found 24 antibody-mediated rejections or mixed rejections, 55 T-cell mediated rejections, 343 that had no rejection, including 47 that were in the borderline cohort. From this data, they found that cell-free DNA would start to elevate or become abnormal up to 4 months prior to a biopsy-proven acute rejection, whereas T-cell mediated rejections showed elevated Prospera levels up to 2 months before their rejection. So again, this evidence underscores the value of Prospera test as a preemptive tool for allograft rejection. The second point from the interim results from the PROACTIVE study includes additional confidence in allograft stability. Prospera essentially was predictive of which individuals were clinically stable over their transplant course in the first year. Clinically stable is defined as individuals with no biopsy-proven rejection, delayed graft function, persistent infections, cancer, or increases in serum creatinine. Essentially, what they found is that if you maintained a Prospera level less than 1% consistently over that first year, it predicted 9 out of every 10 clinically stable patients in the cohort. So again, these proactive study data does build upon the ability of Prospera 2 as a reliable rule-out test for surveillance use. So the third point from the proactive study shows that elevations of cell-free DNA from a baseline does indicate an increased risk of rejection. Of this cohort, they looked at 646 samples from 134 patients, 14 biopsy-proven rejections, 10 T-cell mediated rejections, and 4 antibody-mediated rejections were included. The median time from the baseline donor-derived cell-free DNA to biopsy was 121 days. The baseline established using at least 2 results, and they had to be at least 30 days prior to the first biopsy. Essentially, what we found is that individuals that had no rejection had a pretty stable cell-free DNA. So you had just a very modest increase, maybe up to 1.3 times a median elevation in the no rejection cohort. Whereas if there was a rejection noted by donor-derived cell-free DNA, you could see up to a 60-fold increase in the cell-free DNA percentage. So again, Prospero allows for real-time prediction of rejection risk through continuous monitoring of donor-derived cell-free DNA levels that change against their baseline levels. Donor-derived cell-free DNA has shown to become a very effective tool in the management of kidney transplant recipients. The American Society of Transplant Surgeons have suggested this, as well as the European Society of Transplantation. And of course, it's also included in UpToDate as part of the markers for acute rejection. So you can see that many organizations and societies have started to embrace donor-derived cell-free DNA as part of the toolkit used in managing patients post-kidney transplant. So there's several ways that you can use Prospera in your practice. One is just surveillance, where if you want to draw baseline Prospera, especially like if they come back to your practice after being transplanted, and you can get a baseline of where they're at, and then you can do continuous monitoring every 3 to 6 months as you prefer, or whatever you feel is an appropriate interval. And if they maintain a donor-derived cell-free DNA less than 1%, or if you look at the cell-free DNA count, and if it's less than 78, you can be reassured there's nothing really going on with the kidney and that it's a clinically stable patient. Whereas if you draw the baseline Prospera and then get a follow-up one that shows an increase over 1% or a donor cell-free DNA count over 78, then you might want to consider a biopsy based on other clinical factors. And then if there's a rejection, you can monitor the treatment to the rejection based on the follow-up Prospera levels or the response to treatment, essentially. The other option you can do is clinically indicated use of Prospera. So like if you get someone that comes in with an elevated creatinine and you're not quite sure what's going on, you can draw a Prospera and then consider a biopsy based on the other clinical factors. And if it's a rejection, then you can monitor treatment response with Prospera and use it as needed. Or if you draw the Prospera and it's less than 1% or less than 78 copies for the donor-derived cell-free DNA, then you can feel reassured that, okay, this is probably not a rejection. I may not have to do a biopsy. But of course, if it is elevated over 1% or over 78, then you may want to lean toward biopsy or talk to the transplant center to kind of see what their recommendations are. If there are key takeaways I get from the proactive study and the use of cell-free DNA, is that includes the following. One, cell-free DNA has been shown to be highly sensitive for antibody-mediated rejection. This is clearly defined in multiple studies that cell-free DNA is an excellent marker for early antibody-mediated rejections. I would also consider using this when you reduce immunosuppression for a variety of reasons, which could include infections, skin cancers, or just side effects from the medications that they're taking. It's also especially helpful when you have kind of low or moderate suspicion for rejection. You can proceed to biopsy. If you have a high suspicion, I wouldn't wait for cell-free DNA in those specific cases. But if you have a low to moderate suspicion, then I think cell-free DNA can kind of help you decide if a biopsy is indicated or not. Well, now I'm going to turn this over to Dr. Coleman, who can provide the community nephrologist perspective on the use of cell-free DNA in Prospera.
I think it's really nice to understand the proactive study because And not only do we need to understand who was studied, but I think it's also nice to know how to apply that information to our day-to-day clinical practice, right? So when I look at the proactive study, what I took away and kind of some of the top messages I took away as a community nephrologist is to say, when I approach my post-transplant patient, what am I wanting to do and what am I wanting to look for? Well, first and foremost, obviously, I want to take the best care of the patient that I can. But what I have found with Prospera and what I think the proactive study nicely highlights is that Prospera empowers us to have the ability to actually have an informed dialogue with our transplant center. Oftentimes when we talk to our transplant centers, we may see labs or we may see concerning features of this patient's post-transplant course, but it's nice to have extra data in our toolkit, extra tools in the arsenal, if you will, in order to really talk to the transplant center. So, first and foremost, I think Prospera is a valuable test because it really does predate traditional measures, right? When we look at proactive, we're seeing a little over 420 patients who were essentially biopsied because of some concerning measures, whether it be creatinine, proteinuria, whatever the investigator felt was pertinent. And by adding in that Prospera, what we saw was it allowed us to potentially predict or predate that rejection episode than what our traditional measures would have otherwise given us. And so, I think it does that. And I think this is another very important message to kind of take away with less ambiguity, right? Cell-free DNA offers the ability to have a little bit more confidence, if you will, from a negative value perspective. So when we're approaching as a community nephrologist, our transplant colleagues, and we're saying, hey, look, we have these concerns or we have these considerations, it's nice to have, again, just an extra tool in our toolkit in order to really arm ourselves with the best information. I think, like always, I think this is highlighted in the best format by looking at a case study, right? So this is a patient that I had when really I was still trying to feel my way, and I'm not sure that I have found that way yet, but this is a case that I used really to highlight kind of some of my mistakes, but also looking forward to some of my success with utilizing Prospera. So this is a gentleman who was a 77-year-old Caucasian male who received a deceased donor renal transplant in April of 2018. I was not his nephrologist at that time. He lived in a separate region of the United States. And he received this deceased donor transplant by virtue of unknown sclerosing GN. That was his underlying diagnosis. His baseline serum creatinine was 1.3 to 1.5, status post-transplant, and it had been exceptionally stable for the last 2 to 3 years prior to coming to see me. He presented to my clinic again just because he moved to the area, and his past medical history was really pretty light. He really just only had some atrial fibrillation, well-controlled, rate-controlled, and a hypertension on RAS inhibition and beta blocker. So, if you'll forgive me for some of the heavy data, essentially what we saw was this gentleman with a creatinine of 1.3, 1.5, and I will tell you that remained consistent throughout my clinical course with the patient. Urine protein to creatinine ratio was less than 0.2 grams per day. His tacrolimus levels remained at a trough level anywhere from 3 to 5, very consistent. And initially, when we first saw him in January of 2021, his initial cell-free DNA percentage, his Prospera, was 1.97%. Now, what we did not have was the capability to do the quantitative measurement. In other words, now, of course, we know 70, 75 copies per mil or greater is concerning, but we didn't have that capability. And so I'll pepper throughout what his quants were, but again, we were only able to do that retrospectively. So his quants at that point in time were 107 copies per mil. So when we looked at that information, we decided to retest him a little bit sooner rather than going 3 to 4 months, which would be my normal post follow-up transplant kind of appointment schedule. And so instead, we saw him about 2 months later. We repeated the Prospera, and at that point in time, the fraction was 2.1%, and the quant was about 97 copies per mil. Keep in mind, his traditional measures were stable. His creatinine was 1.5, his proteinuria was negative, 0.12 grams per day. And again, his tacrolimus level was about 4.8. He did have one measure that was a little elevated, but on repeat, it was 4.8. And what's kind of notable about this case is that at that time, I was still trying to get my feet wet and understand really how to use Prospera. And so, I talked to the patient, we discussed, we noted that he was coming up for an immunosuppressant change. And at the time, we said, well, let's just follow these Prosperas a little bit more closely in addition to traditional measures. So the reason why we changed his immunosuppression with the guidance of his transplant center was because he was really starting to struggle with some skin cancers. Non-invasive, but yet still off-putting and certainly bank account draining. And so at the end of the day, we decided to go ahead and change from his mycophenolate to Rapamune in April of 2021. Now, at the time, and again, this is my infancy, and this is one of the mistakes I made kind of in my infancy of using Prospera as a tool. At the time, because of these recurrent skin cancers, I really thought that perhaps these skin cancers were adding to some background chatter. And I think this was just my misunderstanding of cell-free DNA. And so I really thought, well, perhaps this is what has elevated his fraction. And in actuality, if anything, it should have decreased his fraction, right? Looking at that percentage. But at the end of the day, we followed him closely. We followed him actually almost monthly there for a couple months. Again, creatinine stayed stable, 1.3 to 1.5, no significant proteinuria. Tacrolimus levels stayed at goal, if not one or two measures, even maybe a bit above goal. But in June of 21, his Prospera actually increased to 2.86%, and his quant jumped up to about 127. So this is when we really started talking to the patient about the potential of getting a kidney biopsy. As a side note, he really had a very significant and significantly poor renal biopsy that was part of a post-transplant surveillance study that was done at his transplant center. It was done about 2 weeks post-transplant. He vagal down. So he had a really upsetting and really off-putting experience with biopsy. So he was pretty adamant that he wanted to avoid a biopsy if at all possible. We continued to follow him into the fall of 2021. We have data from September, August, October, and again, the creatinine stayed 1.3 to 1.5. His proteinuria stayed right around the 0.2 grams per day. Tacrolimus stayed at goal. Rapamune level was pretty much at goal, perhaps a little bit lower than we would have liked, but still thought to be at goal. And the next Prospera we got, keep in mind, the last one in July was 2.6%, 127 copies per mil. The next Prospera we got was in October of 21, at which point in time his proteinuria for the first time jumped up to 0.5. And then, of course, his Prospera went up to 3% and 162 copies per mil. So it was at this point in time that we really said, look, we understand your experience with the biopsy was off-putting, but, I'm getting really very concerned here. And so we did the renal biopsy. He actually did it at his transplant center in November of 21. And sure enough, he had antibody-mediated rejection. The interesting thing about this case, if you kind of backdate when we started to really see that Prospera elevate, in hindsight, looking at the very initial kind of start to the case, starting as early as January of 21, we saw an elevated percentage or an elevated fraction. We saw an elevated, in hindsight, quantitative measurement copies per mil. But what I like to really highlight is that in April, when we changed immunosuppression, and then in June, where we see that the quant had actually gone down from 107 in January to 96 in March, it jumped up to 127 in June. So then if you fast forward to November, where October, where we see the proteinuria jump up, that almost reflects the study's results, right? So if we say June to October, we're seeing about a 4-month lag time before we see the traditional measures start to really elevate. So I think this is a really interesting case because it's something from the real world that really nicely reflects what the studies show us, which is that, again, the Prospera can potentially predict or predate traditional measures showing the underlying rejection event by about 4 months, again, in antibody-mediated rejection. So just an aside, but again, like I say, the gentleman underwent the biopsy at antibody-mediated rejection, got appropriate treatment, of course, at his transplant center. And actually, the kidney itself did great. He himself, unfortunately, had a really significant hospital course, which really included some peptic ulcer disease from kind of some of the prednisone loading that he had done in response to the biopsy. Had a really significant hemorrhage, GI hemorrhage, ICU stay, intubated. Got some infectious complications along the way, COVID, E. coli, both urosepsis and bacteremia, and unfortunately was kind of in and out of the hospital for a couple of years, for a couple of months. But what I'm really happy to say is that as of February of 2022, his creatinine was 1.47. His proteinuria was 0.38 grams per day. And so again, what we see here is that despite this really clinically significant rejection event, the patient's kidney was able to survive with the appropriate therapy. And I suspect with the appropriate therapy, he may have even had a little bit of a better recovery of kidney function. Obviously, we can't say whether he would have had less complications. That's out of the scopes, clearly. But at the end of the day, it was nice to see the Prospera in action and really kind of see what it was allowed us to at least have more information to utilize when it came to the evaluation of our post-transplant patient. So what kind of takeaways do I take from this case, and what do I want you to take away from this case? Well, I think what we see here is that serial monitoring was really valuable. Here, the human error and the human lack of action was what was not so valuable, right? But what we saw is that in the real world, it really reflected similar results to the study design. We also noticed that, at least again, clinically speaking, when we changed the patient's immunosuppression, monitoring was extremely useful and extremely valuable to kind of really show when that patient started to kind of slip into a rejection episode. And ultimately, I think because we caught it early, we overcame that 4-month lag period where I was really trying to convince the patient to do a biopsy from June to October. I think because we had already done the hard work to talk to the patient over the course of that time, I think what we see here is that if we had waited until October to start that conversation, he could have very well gone on into 2022 without having the biopsy and really may have had a more detrimental outcome for the kidney. Also, the Prospera really gave me the confidence. And if I had more confidence and my understanding of the Prospera test had been better, I think it would have enabled a more prompt rejection treatment for this patient. And really, at the end of the day, the Prospera just enabled me to have a more robust clinical conversation when advocating for my patient to the transplant center. Again, this is a transplant center that was out of state. They didn't know who I was. They knew, of course, who the patient was, but it had been many years since they had seen the patient. And so to have that extra piece of information to add to the clinical conversation, I think was uniquely really kind of a relevant and beneficial aspect of this patient's case. So looking at all of this and looking at this case, I think it really highlights where serial monitoring and surveillance monitoring, again, perhaps not for cause per se, or perhaps for cause for something like immunosuppression changes, I think it can be very beneficial in the long run to fit into your clinical practice, again, to be an extra tool, an extra measurement, an extra lab that allows you to more robustly take care of your patient. So with that being said, I'd love to get Dr. Akkina back and hopefully have a little bit of a conversation about really kind of what he thinks from a transplant nephrologist perspective and how he utilizes Prospera and how it aids in basically the conversations with the general or community nephrologist in the post-transplant world.
I think your case brought up a lot of really interesting points, and I think that communication with the transplant center really is helpful, especially knowing kind of what you've already looked at and using that cell-free DNA to kind of provide that extra additional information, I think was really helpful. And I kind of run into this also, like occasional cases too, where a patient of ours has gone out to back to the community nephrologist after their first year post-transplant. And then they'll come back maybe 6 months, a year, or 2 years later saying, hey, we've got these elevated cell-free DNA levels. kidney function looks okay, but we have these elevated cell-free DNA. It's been persistent. What should we do with it? So we've had these conversations with the community nephrologists, and ultimately biopsies will occur, and we do find that there are some interesting findings in some of these patients that do come back with these abnormal readings. So I think your case is a great example of how it's used out in the community and how it can help transition a patient back to a transplant center if needed.
Well, thank you both for that really interesting presentation. I really enjoyed it, and I'm sure the audience learned a lot. And now we'd like to do some questions and have a discussion. Dr. Coleman, why now for general nephrologists? Why should nephrologists educate themselves to feel comfortable in managing kidney transplant patients?
So I think that the call to arms, if you will, why should a community nephrologist start to really educate themselves and feel comfortable or work towards feeling more comfortable taking care of the post-transplant patients? I think there's several reasons why this is so very important. I think, first and foremost, as our population ages and as our immunosuppressive regimens and the care of our transplant patients improves, I think what we're going to see is that the transplant population is a growing population, and that's our goal, right? Our goal is to get patients off dialysis and into the transplant population, or hopefully even skirt dialysis from the get-go and preemptively transplant them. And I think not only is that a goal of ours as nephrologists, but I think now it's even essentially federally, maybe not federally mandated, but federally recommended, right? The Trump executive decision on kidney health really highlighted the need for not only preemptive transplantation of kidneys, but certainly the evaluation and the increase in education of our CKD population such that they become better transplant potential candidates. And so as a result, I think as this population grows, what we're going to see is that the impetus to take care of these post-transplant patients comes back to the community. I think our transplant centers have done an excellent job not only identifying and also transplanting our patients, and then certainly subsequently taking care of them for the first year post-transplantation. But I think they've done an excellent job of also taking care of these patients even longer than that first year. And quite frankly, at this point in time, I think they're inundated, right? And so it becomes our role to take our patients back to simply free up time in the day for our transplant colleagues to see new patients. And so as a result, as this population starts to come back to us, I think, at the end of the day, we need to arm ourselves with all the tools that we can in order to make sure that we have the right information as a general nephrologist to take care of these patients. And then also to be able to go back to the transplant centers and say, hey, look, here's what I'm seeing, and this is my concern. And so at the end of the day, I think that, again, the more data, the better, right, when we take care of our patients.
Dr. Akkina, what are your thoughts on the matter?
I think Dr. Coleman has said everything I was going to say. Really, I think she did a fantastic job explaining that. I think especially the bigger issue from a transplant center, as we start doing more and more transplants, it's harder for us to follow up on these patients after that first year. And of course, a lot of these patients want to go back to their community nephrologist, and I think a lot of their nephrologists want the patients to come back. So, I think it's important to make sure that we get patients back out to the community, not only for the patient and for the nephrologist, but also for our own transplant center, where we just start to get overloaded with the number of patients we have to follow. And I think working with the community nephrologists to ensure the best care for these patients is important. And that's where I think additional testing, diagnostic tools such as Prospera become very helpful.
Dr. Akkina, how are you thinking about monitoring your longer-term post-transplant recipients with this new technology?
That's a great question. I think at our center, we're still trying to figure that out. Once patients start to go back out to the community, how do we want to make sure that we can work with community nephrologists to follow this testing? And we're still trying to iron out the protocol. I think a lot more data from Proactive will help us decide on how long we need to go. If it's still quarterly testing for the first 3 years, for the first 5 years, or will yearly testing be enough? I think we're still trying to figure that aspect out. But I think there's still a lot to learn from this. But certainly, I think, I know my colleagues have really started to appreciate the use of using Prosperas more frequently to help with kind of monitoring these patients. post-transplant, especially after the first year.
Dr. Coleman, what are some key best practices for a general nephrologist to think about as they are working with their transplant centers to co-manage their patients?
I think I think there's a lot of best practices, but I think first and foremost, when we talk to our referring transplant centers, I think that the more information that we can have in order to set them up for success is better, right? I look at the pre and the post transplant patients as actually very kind of similar. Pre-transplant patients, right? We arm ourselves with information, or the transplant centers arm themselves with information. They want to make sure that if they put that kidney in that patient, that it has the best chance for success possible, right? Well, the script just gets flipped in the post-transplant world. We see those patients every 3 to 4 months potentially, although I know certainly in the community, as we are getting inundated with more and more CKD patients, I know we may even push them to 4 to 6 months, right? And so I think at the end of the day, when we're looking at a patient, of course, we're going to get our traditional measures. We're going to get the creatinine. We're going to get the urine protein creatinine ratio. We may even get, for example, in our practice, we'll do the annual BK screening for a non-at-risk, just surveillance testing for a post-transplant patient. And so I think one of the things that I'm still working on figuring out in my own clinical practice is, how does Prospera fit into that? And so certainly for the right patient, we're screening them every 3 to 4 months. For different patients, we may be doing every 6 months. We have some patients we're just doing once a year per patient request more often than not. But it's interesting as you start talking to your patients, because of course this is a separate lab draw potentially from the other labs that you're having them do for your routine follow-up appointment. I think that when you present this test as a test that may potentially show a rejection episode well before kind of some of the traditional measures, it's interesting. The enrollment of my patients and the acceptance of this has been paramount. They're very interested in protecting their kidney. And so again, the more information that we can provide to our transplant colleagues in the post-transplant world, especially when we think that there's the potential for problems on the horizon, to me, I think that's how we can best work with our referral centers, and then also hopefully give us the confidence to talk to them and them the confidence to evaluate our patients when we need their help.
Dr. Akkina, as a transplant nephrologist, are there any best practices you'd recommend for general nephrologists to think about as they're working on co-managing their patients with their transplant centers? And how do you put these best practices into place today?
So for best practices from a transplant center perspective, I think, for the community nephrologist, at least my suggestion would be, if you're going to try to use cell-free DNA, I think getting that baseline when they first come back to you, or back to your care. So, from our center, we usually let them go at 1 year. And, so they'll probably see them 3 months after that 1 year visit. So somewhere around that 15-month visit, it may be worthwhile to get a baseline value if we haven't already gotten one. And then I think from there, you kind of decide whatever frequency that you feel is appropriate, 3 months, 6 months, 1 year, and kind of do that as surveillance, as you mentioned, with your routine labs, just to kind of say, like, you want to use this as an additional tool to figure out if there is something going on. I think the other thing, clinical practice wise, I think the use of it from a clinical indication, I think, is also helpful. If you're not necessarily if you're not going to use it for surveillance, I think as a clinical indicated tool, I think it's an important tool to use as well, because it can eliminate that need for doing a biopsy that may be unnecessary. If you add a kind of a low or moderate suspicion, then I think it's worthwhile to do a Prospera just to kind of help decide, do I really need to do a biopsy, or can I just wait it out and give it a little more time? And I think, a negative value, I think the tests have all shown that cell-free DNA is a great negative tool and this negative predictive tool. So I think it works really well from that perspective. So I think, if you're going to use it for surveillance, get a baseline right at the beginning, and then and go from there. Or if you're just going to use it for clinical indications, then I think that also works really well. In coordinating with our general nephrologist or our referral nephrologist, usually we would tell them that this is kind of the test that we've been using for our center, and if they decide that they want to continue that I think that's totally fine. And we would kind of say that we've been doing them every 3 months or 6 months or whatever we've been using as our surveillance practice. And I think we can also work with the nephrologist to say, we send them that report that we have at 1 year, just to say, okay, this is what we've gotten. So if you do follow-up testing, you can use this for your baseline. and follow that from here on out. Or if they prefer, we can also have them just have the patient do the test with us, and then we'll just continue to follow well, and then obviously let them know if there's any concerns or issues.
Well, I'd like to thank both of our speakers for this very insightful discussion on how transplant and general nephrologists can work together as a single care team with the goal to prolong the life of our patients' kidney allografts. Don't forget to subscribe to hear even more conversations with our transplant and general nephrology colleagues on new and upcoming data and how they are interpreting it to care for their own patient populations. Thank you.